Good afternoon, everyone. Welcome to the 32nd State Level Annual Conference of Karnataka Association of Community Health hosted by Ramaya Medical College. The, the theme this year is Redefining the Public Health COVID-19 and Beyond. With this, we shall begin with our session 3. Let us take this opportunity to introduce our esteemed judges for today's oral presentation faculty. We are thankful for dedicating your precious time to judge this session.
So today's session will be moderated by our respected Dr. Sunil Kumar, Professor and Head, Akash Medical College, Bangalore, and Dr. Ashwini Kumar, Professor, Kasturba Medical College, Manipal. Please start the video, everyone. So here, let's go through the instructions for today. So download the WebEx application before for smooth functioning. Log in 10 to 15 minutes early. Do not log in from your mobile phone. Make sure you have an uninterrupted internet connection. Make sure you enter WebEx meeting with the name of your own name. Make sure your camera and microphone are functioning properly. Make sure you are seated in an isolated and closed space with proper lighting. Mute your microphones when you are not speaking. Minimize distraction from the background and avoid echo. Stay seated and stay present. Stick to the given time. The time frame will be like the 6 minutes to be given for the oral presentation and 2 minutes for the question and answer should be given. Your presentation will be stopped if you are exceeding the given time. We request everyone to kindly cooperate to the successful conduct the event. So here, I'll request the first participant, Dr. Vijay Lakshmi among Suli. Can you please start the first presentation? We are welcoming you.
Yeah, can I share my content?
Share the presentation.
Yeah.
Share option is not coming.
Is it visible for you?
You are controlling the thing?
No, we will give you the control. Wait a second.
Hello? Yeah. Yeah, can I change this slide to shift to the next slide?
Yeah.
Dr. Vijay Lakshmi, we are giving the control to you, the PPT.
Okay.
Yeah, we are making you as a presenter. You can present your PPT, or shall we present your PPT?
No, I'll present. I can change
We
the
cannot hear
slides
you.
according to my presentation.
That's good.
Can change the... Hello? Oh, can you hear me?
Yes, we can.
Okay. Yeah. Good afternoon, everyone. I'm Dr. Vijay Lakshmi, Assistant Professor in Basveshwara Medical College. I'm presenting my study on risk assessment of COVID-19 infection among general population. As we all know, COVID-19 has been declared as pandemic since March 2020. Best ways of preventing this virus is to know about it and act accordingly. And with this background, we have done this study to assess the risk of COVID-19 infection among general population. We have done community-based cross-sectional study. Among 185 general population aged more than 18 years residing in urban field practice area in Department of Community Medicine, BMC Chitradurga, for a period of 3 months. We have done a house-to-house survey with a pre-designed semi-structured consisted of 24 questions. We have collected the data regarding their attitude and practices towards the COVID-19 infection. And based on their attitude and practices, we have assessed the risk, then we have scored them, then we have, depending on the score, we have categorized the risk as the score as 20 and more as 15 to 20 as high risk, 10 to 15 as a medium risk, 5 to 10 as a low risk, and less than 5 as a no risk of infection. So when we study, this is the socio-demographic variables of study participants. The majority, that is more than 50%, belong to more than 40 years. 23% in the age group of 40 to 50 years, and more than 60, that is elderly age group, belong 25% of our study population, and majority were males, that is 54%, and 89% were 58% belong to nuclear family, and 66% were married, and the 25% had completed their high school education. And when we saw the occupation, the 27% majority were unemployed, because we have taken both males and female. And socioeconomic status, according to modified physical classification, 33% belong to class 4, followed by the class 3 status. And we have studied their BMI also, along with the socioeconomic. 60% belong to overweight category, and around 20% were also obese. And to assess the attitude and practices, we have asked 24 questions. This is the regarding washing the hands. Raise their answers. 50% have washed their hands with soap and water. 60% they use the regular use the mask regularly. They have gone to the mask outside with the proper cleaning. 44% wash the dress. And 46% they spend the time with their friends regularly. We have asked to assess this regarding attitude and practices, and regarding some minor questions like cleaning their mobiles and regular articles with soap and sanitizers. There were very few, I mean, less than 50% have these minor questions. And the important thing is, they are working around only 4%. COVID-19 symptoms, they have the um, colleagues with the positive symptoms also. So depending on that attitude and practices, we have scored with a Likert scale, and we have assessed the risk. 39% were at low risk, 36% were at medium risk, and 10% are at high risk, and 2% were extreme high risk, and 13% had no risk of getting infection. And when we have studied their association with the demographic factors along with the BMI, with the risk of infection, we have found a significant association between their age, gender, occupation, and BMI. And also, with respect to unemployment and employment, we have divided into two categories to have a binary logistic regression. Uh, to conclude, attitude and practice towards the prevention of COVID-19 is fairly good among general population of our study area, but still more than 30% of the population is at risk of getting infection. Increased age, female gender, employers, and obesity are the factors which are significantly associated with the risk of infection. So appropriate preventive measures, healthy practices, and instruction must be strictly implemented in their workplaces. Moreover, we can implement the strict actions which were given by the WHO and UNICEF. These are my references. Thank you.
Thank you, ma'am. That was a very great presentation. So now we are moving to the next participant, who is Dr. Varsha R. Mokshi. Welcome, Dr. Varsha R. Mokshi.
Ma'am, can you
Yes,
please
thank
stop
you.
your
Can you, am I audible?
Vijayalakshmi, ma'am?
Yes, ma'am.
Hello.
Yeah. Wait.
Stop sharing your screen.
I'm not getting. Stop share model. Share. Stop sharing. I stop.
Next.
So we are welcoming the Dr. Varsha or Mokshi.
Yes, thank you. Am I audible?
Yes, ma'am, you are audible.
Okay.
Ma'am, you are able to share your screen,
No, I don't have the option yet.
or should we share?
No, I will share. Please give me the permission to share it because I cannot see the
Okay.
permission yet.
Is it able to share?
I'm sorry for the delay.
Actually, the Vijayalakshmi ma'am, can you please stop your screen sharing? Actually, you did not stop. We are not getting the access to share it.
We have stopped. I am getting the share content option also.
No, you cannot. We have to share to the context. Did she know?
I think ma'am is still the host. That is why I'm not getting any option.
She's asking us to share.
Yeah.
Ma'am, you have to stop sharing your screen, ma'am, or else we cannot take the access. Just tell stop sharing.
Stop share.
Yes.
May I open? Can I leave the meeting? I am not getting that stop share.
Ma'am, you can leave the meeting once. We will admit you again.
Okay.
Yeah. Yeah, we'll share your PPT, ma'am. Varsha.
Yeah, give me the permission. I'll share it.
You can see the PPT, ma'am.
No, I want to share it myself because I've made some changes. So make the host so
Should
that
we give the
I'll
control to
share
you?
it. Yeah, please give the control to me.
Should we make her? No, don't make her a participant. She wants us to present, right?
No, I will present.
Hello, Varsha.
No, not presented. I will present it myself.
Yeah, ma'am. You can access the screen right now.
Don't have the share content option. I will be sharing PPT. So please close this one so that I will share my PPT from my system.
We should make her a participant. One minute, ma'am.
Okay.
You can present it now, ma'am.
I'm not getting share screen option. I can share now. Are my slides visible?
Yes, ma'am. Now it is visible.
Just a minute.
When she tells start, I'll start.
Okay. I'll start now. Good afternoon, everyone. I'll be presenting my research topic titled Knowledge Attitude Practice Among Adolescent School-Going Children Towards COVID-19 conducted in Kolar. The coronavirus disease 2019, that is COVID-19, emerged in Wuhan, China at the end of 2019, and the battle against COVID-19 is still unending. People's observance of the prevention measures is essential for controlling the spread of the disease, which is affected by their knowledge, attitude, and practice. Among the lessons learned from the previous SARS outbreak is that the knowledge and attitude are associated with levels of panic and emotion, which could further complicate measures to contain the spread of the disease. So children can actually change agents in the society if they are given the correct information. They can teach people around them. Hence, this study was planned to assess the knowledge attitude practice of adolescent school-going children towards COVID-19 during the pandemic. The objectives of my study were to assess knowledge attitude practice of adolescent school-going children towards COVID-19 and to assess the association of knowledge on their practices towards COVID-19. This was a cross-sectional study conducted in a private school in the field practice area of Kolar between May to August 2020, where school-going children in the adolescent age group, that is 10 to 15 years, were included. A sample size of 384 was calculated by considering 50% as the proportion of knowledge among them. This is a brief procedure of the study, where a private school in the field practice area, which had a school with online teaching program available with WhatsApp or Zoom, 384 children were selected and knowledge attitude practice were assessed among them. And the data was collected by using Google Form.
Sorry for
So,
disturbance.
socio-demographic profile of the participants are as follows. There was equal representation among the different age groups as well as gender, but most of the children belong to APL group when compared to PPL group. Table 2 shows the distribution of the study participants as per knowledge. The knowledge was divided into three parts, the questions, that is K1 to K5 regarding the clinical presentations. These were the questions asked. Whereas K6 to K10 were regarding transmission routes of the disease and K11 to K15 were regarding prevention and control. The scores were given as follows: 1 mark for correct answer, whereas 0 for wrong answer. And the distribution of study participants as per attitude was as follows, and there were 6 questions, and the scoring system was the same: 1 for correct answer and 0 for wrong answer. Table 4 shows the distribution of the study participants as per practice for a total of 14 questions regarding the hygiene practices towards COVID-19 as to prevent the disease or mitigate the disease among others were asked. Here, it was divided into always, sometimes, and never among the practices, which were scored as 2, 1, and 0 respectively. This is a table showing the repeatable statistics where the reliability of the study scale is measured. Both mean and median of knowledge attitude practice were almost the same. That is, mean values for knowledge was 11, attitude was 5, and practice was 23. And the Cronberg alpha was applied, which is a coefficient of scale reliability. And for knowledge and attitude, we found a value between 0.6 to 0.7, which means that the scores are acceptable. And for practice, the score was 0.8 to 0.9, showing that it was a good scale. So following this, we did a regression analysis for our second objective, where we found that knowledge had a statistically significant effect on their practices, okay, when compared to the other independent factors as well, like age and gender. With increasing age, the practices were more better, and also females showed a better practice towards COVID-19 when compared to males. And knowledge also was found to have a positive impact and a statistically significant effect on the practices of related to COVID-19. So this study revealed that adolescents showed a good base of knowledge regarding COVID-19 and the mean knowledge score was 11 out of 15. They also tended to hold positive attitude towards the country's curfew and other protective measures put forth by the country. So the mean attitude score was 5. The majority reported committing to healthy practices and mean score for practice was about 23. However, there was a relatively small yet clinically significant percentage of adolescents who showed poor knowledge on COVID-19, had negative attitudes towards protective measures, and reported being engaged in risky practices. These findings were in line with another study among the adolescents in Jordan, which was conducted recently and published in 2020. So to conclude, adolescents represent 1/3 of our population, and in a pandemic such as COVID-19, KPs of this population can affect the future spread of disease. The results appeared promising. More tailored efforts are still needed to improve the levels of the knowledge attitude practice among them. Adolescents can be an important
When your time is over.
getting Right.
Yeah.
Thank you.
So there is 2 minutes for question and answer for you. So
Okay.
I'm requesting judges to for putting question and answer for Dr. Varsha ma'am.
Can I stop sharing?
Judges, you can ask the questions from the Dr. Varsha ma'am. It's 2 minute time for the questions and answers.
Varsha, why you selected only adolescent age group?
Sir, we selected the school-going children, and adolescent children are also considered as change agents for most of the conditions in the society. And similarly, in a pandemic situation like this, for mitigation of the disease, I think they are the more receptive population. So that is why adolescent.
Do you think how exactly they will further help in propagation of knowledge?
Is multiplicative effect among school children, sir. So among their family members and also in the society, they'll form an important source for spreading the knowledge, sir.
It was not clearly audible. That's why I'm again asking. You are giving them questionnaire and asking them to fill up and give you back.
So it was through Google platform, sir, because it was still during the lockdown time, and we used the school education so that they could communicate through the principal and the teachers, sir.
Oh, thank you.
Thank you, sir.
When will happen this? Just
Thank you, ma'am.
Should I stop sharing? Okay.
Yeah, you should.
Thank you so much.
Thank you, ma'am, for the great presentation. Now we are moving
Thank
to
you, sir.
the next participant, Dr. Shushma HR ma'am. You can start the presentation. Sorry for the one delay. I will share your presentation. Yeah.
ma'am, the Varsha ma'am, please do disconnect your sharing part, or either you disconnect and again participate in this. Because if you do not disconnect, we cannot share. Yeah. Yeah. Thank you, ma'am. Next presentation is.
Welcome, Dr. Shushma HR ma'am.
Can I share my
Yeah, I can make a presenter. She wants to present. And you want to present or should I make it presenter?
Yeah, I want to share this.
You want to share?
Yeah.
Okay, you want to share. Let's make her a presenter.
Yeah, I got it.
Yeah, you can share your PPT number.
Is my screen visible? Is my screen visible? Okay. So, good afternoon, everyone. I'm going to present this video on a professional study in fixing misconceptions regarding the usage of masks during COVID-19 crisis among the general population in India.
Sorry, ma'am, you are not audible.
Hello. Am I audible now?
Mm.
I'm going to present a study, cross-sectional study on the myths and misconceptions regarding the usage of masks during
Ma'am,
COVID-19.
can you please start again, ma'am? Actually, your voice is not clear and we cannot hear you, ma'am. Because if we start the time once, then if time completes, we cannot help there.
Okay. Is it audible?
Can you be loud, ma'am? Little?
Yeah. Hello?
Yeah, ma'am. We'll start your time, ma'am.
Yeah.
Judges, can you hear her?
Good afternoon, everyone. I'm going to present a cross-sectional study on the myths and misconceptions regarding the usage of masks during COVID-19 pandemic among the general population in Karnataka. So, coming to introduction, as we all know, 2020 was the novel SARS-CoV-2, which is mainly spread by droplet transmission, and people can easily catch COVID-19 if they breathe in waste droplets from a person infected with the virus. So, as recommended by WHO, that face masks are given a potential shield to tackle the COVID-19 pandemic. But the data for the mask usage and efficacy are still limited. As we all can see in this chart, there is a cumulative increase in the number of cases. So, as it, the study was done during the lockdown period, that is in the so there is an increase in the number of cases. So, in general public, this we should have a good understanding about the face mask. Thus, the study was conducted to understand the mask usage and the myths associated with it. So, the objective of the study was to explore the myths and misconceptions regarding the usage of face masks to prevent COVID-19 infection in the general public. Coming to materials and methods, it was a cross-sectional study in the general population of Indian Karnataka was considered, and participants aged above 18 years with the informed consent was included. The duration of study was from 13th April to 14th May, that is 1 year. And this was during the lockdown period, and the sample was a convenient sample to get the participants to not more participants by taking the opinions from previous study. The method of data collection was through communication by using a Google platform, and it was circulated through social media. It was circulated to the general public, which includes our neighbors, vendors, doctors, etc. And the specific analysis was taken from the coming to the table 1 shows the social demographic quality, which shows that majority belong to the young age group, that is 84%, and male and females are almost equal in number, and 64% of youth in our study, and they earn from 12,000 to 30,000. The according to digital medical digital classification, majority belong to class 1. And then second question is type of mask used, which is the patient flow, followed by HPI and mask. So there are also questions regarding the face mask. So the last question is, could you hear which denote the usage of mask? The person replied, no. So it is not like there are people getting COVID tested because of the usage of mask. And when we asked if they believe it's only in COVID-19, 44% were not sick, and 71% said that the usage of mask is not alarming, and also the young and healthy have to wear face masks always, according to 85%. So we asked about any fake news regarding the usage of masks, person replied no. And they asked if they believe that they can completely protect from COVID-19, 73% said no. Now, then we actually some mathematical test basically in knowledge and belief the same around 33% of the students and knowledge regarding using the face mask and 50% of the students. Then they asked the questions about the face mask, like who knows do you have these questions to use sanitizer? 4% said no, it's good, and 8% applauded
Ma'am, only 1 minute left to conclude your PPT.
Yeah, sure. So one question regarding frequency. And the conclusion is majority of good knowledge very consistent is not good, which will be the 53% to listen to mass, which needs to be defined, followed by education and lifestyle. And the next, like, hearing any rumors and all, they're like minimum. So we thought that the general public should be educated more. And 17% is the completely productivity stable beauty. And also 86% of people will have to list. So the general public is gradually shifting their moving on and face mask. Like we see recommendations in we like avoid makeup, people will use face mask and educated people proper using this mask. And also the mask will be in a different way. And also we should educate them regarding the use of sanitizer and
Ma'am, your time off. Now, 2 minutes given for the question and answer. I'm requesting that you ask the question from now.
should I stop sharing?
Yeah, you can stop sharing, but it's time to for the question and answer.
Yes, yes.
I am requesting Dr. Sunil sir to ask the question from her. So we can't hear you. So you are not audible, sorry.
Krishna, can you hear me?
Yes,
I am Dr. Ashwin. I just wanted to, I couldn't hear you properly. I just wanted to know your recommendations are based on your study findings. Like you are
yes,
saying, you should use triple mask layer and all that. Was that
yes,
based on the study findings or it's general recommendations?
yes, it's based on the study also. We found that most of them are using cloth masks. And in that few included doctors also. The general public included doctors, engineers, healthcare workers, everyone. So we recommend at least for the healthcare workers should be using triple layer masks. So, am I audible?
So you are not audible.
It's not audible, madam.
Yeah, it's audible now, sir.
What is the, you are talking about misconception and myths. What is the truth about the mask? Why you should wear mask? You ask that questions?
Yes, sir. We asked them like, why do you want to use masks? So most of them were like, we don't want to get infected or the filtering capacity, but very few knew about that. And but we didn't apply any tests to know which type of mask is good or to check its efficacy.
For example, example, why no washable cloth mask you are wearing? What is its use? How it exactly prevent the transmission if it prevents?
Yes. That's what most of them will like use a cloth mask. So we wanted to make them understand the route of transmission, how to disinfect the cloth mask and all. But
So we are
Okay,
running out of the time.
there's a fault in your mic. I think it's not clearly audible. There's a lot of interruptions. Anyway, thank you for your presentation.
thank you.
Thanks for the wonderful presentation, Dr. Shushma ma'am. Now we are moving to the next participant, Dr. Bhushra Jabin ma'am. So ma'am, can you please turn on your video and unmute your mic?
Shushma ma'am, can you please log out or stop sharing your screen? Or else we cannot give a control to the next presenter.
Good afternoon. Am I audible?
Or you can log
Yes,
out
ma'am,
and
you are
log in,
audible.
ma'am. Yeah, thank you, ma'am.
I would like to share a PPT from my own system. Please give me the controls. I would like to share the PPT from my
Yes,
own
ma'am. Yes,
system.
ma'am. Wait a second.
Yeah, ma'am.
Okay.
You can
Now you
share.
can share, ma'am.
Share, ma'am.
Uh, okay, is it visible?
Yes, ma'am. It is visible.
Okay. So good afternoon, everyone. I am Dr. Bushra Jabin. I will be presenting a cross-sectional study on knowledge, attitude, practice regarding COVID-19 and its apprehension among house surgeons. So here initially regarding the current scenario, at present we have nearly 3 lakh active cases in India itself, and majority of these cases are in states of Maharashtra and Kerala. Whereas during the first week of March, when the coronavirus was spreading like a wildfire, and the impact of this coronavirus was not known much. Neither was the details of the virus known to the population, and it had an imperious impact on population, not just the general public, even on the healthcare staff. So any pandemic or epidemic causes a stress or panic reaction among people, and these stress factors were seen in the form of physical, behavioral, emotional, cognitive reactions. In a study conducted by Bhagwatala et al., it was seen that a significant proportion of healthcare workers had poor knowledge about the transmission of the disease as well as the symptom of the disease. Another study, which is a meta-analysis, a systematic review was conducted in which it was seen that majority of the proportion of the reactions were in the form of anxiety, depression, or insomnia. And in a study conducted in China itself, it was shown that among the healthcare workers, more than 80% were preoccupied with the thoughts regarding the infection, and 36.4% were distressed due to the social media. Now, in the throughout system, we found that the data regarding impact of COVID-19, especially among the healthcare workers, was very limited. So, with the aim to assess the prevailing knowledge, attitude, and practice, and assess the apprehension of COVID-19, especially among our budding doctors, this study was conducted. And this study is basically a cross-sectional type of study wherein our source of data was collected from house surgeons who were working, especially in KIMS Hubli as well as in other medical colleges. The duration of study was 1.5 months, and we used convenient sampling method to select our study participants as it was difficult to get them on hand. And a semi-structured questionnaire was framed on Google Forms, and it was circulated among interns or house surgeons to various social media platforms like WhatsApp, emails, etc. And for analysis purpose, we have used MS Excel as well as SPSS version 20. Now, talking about the results, firstly about our study participants, majority of our study participants were house surgeons in Cambridge itself, whereas just 28% of them were from other colleges, and majority of our house surgeons were residing at hostels. And talking about the knowledge, uh, a total of 15 questions were asked to assess the knowledge of the study participants. And by assessing, we got to know that around 57% of our house surgeons were trained in how to use personal protective equipment, and more than 85% of them believe that avoiding exposure is the best way to prevent and control infection. And majority of them also thought that droplet infection was the mode of spread of infection. And they were also well aware of the most common clinical features of COVID-19. They were fever, cough, shortness of breath, as well as sore throat. According to the knowledge assessment, it was found that 31% of the house surgeons had adequate knowledge regarding the current COVID-19 situation. And talking about the attitude, though the study participants were worried about themselves or regarding their family, but still they had the enthusiasm to work as a frontline for similar epidemic courses if it occur in future, and they also did not freak out by thinking of quitting the job much. Just 16% of them had ever thought of quitting the job, but majority, that is more than 85% of our house surgeons, work passionately regarding towards the end of this COVID-19. Next, we're talking about the practice and apprehension. Each of these were assessed with about 15 questions. And regarding the practice, it was seen that 72% of our house surgeons had good practice regarding COVID-19, as if they had good habits of washing their hands very often, having baths as soon as they reach back their homes, and avoiding to meet others, and isolating themselves, etc. And regarding the apprehensions, firstly, they were more feared about their family members of getting infected with the COVID-19. Other changes that were seen among house surgeons were that they had changes in their eating habits, in their sleeping patterns, and they had generalized body aches, and some of them had difficulty in concentrating in work, whatever they were doing. So to summarize regarding apprehension, I would
Ma'am,
like to
only
tell
one
that
minute time left to conclude your PPT.
Okay, so 82% of our house surgeons had a sleeping disorder in the form of at least having bad dreams or weird dreams or being not active even after a full sleep. So to conclude, I would like to tell that though house surgeons had their own feared factors, but still they were passionate about their job, and they worked no matter what was the situation. So to keep up this spirit, I would recommend to supply them more materials required during the situation, and guide them appropriately how to use these personal protective equipments more efficiently. And also a mentor can be allotted to a group of house surgeons so that they can discuss the difficulties they face during their duty. With this, I end my presentation. Thank you. These were some of my references.
Thank you, ma'am. That was such a great presentation. Now it's time for the question and answer, so you can start the questioning. So unmute yourself, please. You're not audible.
Basra, I'm Dr. Ashwin here.
Yes, sir.
Yeah, again, your recommendation seems to be general. Is it the outcome of your study findings?
Sir, as per the outcome of my study findings, sir, because some of the interns had told that on duty they face difficulty when they do not get personal protective equipment, or they do not have anybody to discuss their problems with. So majority in our study was also actually seen that majority of them are discussing their problems with their family members who may or may not be health professionals. So it would be better if they have a mentor from our field itself to guide them.
That is true, but the objective of study is not that to find out their knowledge,
Actually,
expertise, and all that, and ultimately you're recommending something which is known to everybody. Is that true?
so it was actually regarding it, because as in the study, it was seen that 31% of study participants were having adequate knowledge about the situation, the COVID-19.
You found
And so
anybody who is not properly putting their PPE, and that's why you're recommending they should be trained to put the PPE properly or something like that? Because your
uh,
recommendations come from the study findings. That's why I'm saying. General recommendations are different. You said the PPE should be not, they should be trained to put, there should be adequate PPE and all that. Is the study findings or the general recommendations?
Uh, it was, I assumed it was a study finding, sir, but now I think it is a general recommendation because this was the common problem which I think most of the teachers have faced.
Yeah, yeah, common findings are fine, correct. But no, in a scientific presentation, what you find, you tell in the results and accordingly you recommend. Is that okay?
Yes, sir, sure, sir. Yes, sir. Thank you, sir.
Okay.
Reply to Dr. Sunil, sir. My major findings regarding which was regarding assessing knowledge, practice, and attitude, sir. It was that they had adequate knowledge and positive attitude, and they had good practice also. And whereas regarding the apprehension, in this study, it was found that most of them were feared for their relatives, and they also had sleep disturbances either in the form of waking up in the night due to bad dreams or weird dreams, or not feeling very refreshed after having a complete sleep. And they also had some other apprehensions, like they felt very nervous and anxious whenever they are facing in COVID-19 patients.
Thank you, ma'am. Time over. So it's
Thank you.
that was such a great presentation, ma'am. Now it's time to move on to the next participant. She is Dr. Pavitra Achalraj, ma'am. We are welcoming, ma'am. So,
Ma'am, ma'am, can you
Yeah,
please stop sharing
yes,
your
I'm trying.
PPT?
Dr. Bushra, ma'am, can you please stop sharing your
Yes, yes,
PPT?
yes.
Good evening. Am I audible?
Yes, ma'am, you are audible. Good evening, ma'am.
I'll be sharing my presentation from here.
Okay, ma'am.
Share it.
Wait, ma'am.
Okay. 1 minute, ma'am.
Sorry for the delay, ma'am. 1 minute.
Okay. Can you give me the access?
Yes, ma'am. Wait a second.
I want to share it from my system.
I'm making you a presenter, ma'am. You can present.
Can you share, ma'am? Is it accessible for you?
No,
No. Wait a
Try
second.
now, ma'am. Try again.
And try again.
no,
We have given access to you.
no, I'm not able to do it.
Wait a second, ma'am. Okay.
Ma'am, we have given the access, ma'am. You are
Yeah, the
unable to
share
present.
button is not enabled.
Okay, 1 minute. Ma'am, actually you are logged in from two devices, ma'am. There are two Dr. Pavitra, I think so. That's the confusion.
Okay, I'll just log out from one.
Two names are there, Dr. Pavitra. Okay, I cannot.
Okay. I have logged out from one.
So, ma'am, can you share from here?
Yeah, that should be better.
Can you share from here?
Yeah,
Wait.
Yes, ma'am, you can present your presentation.
I can't see my presentation.
Okay, ma'am. 1 minute, ma'am. 1 minute. Ma'am, will make you a participant, ma'am. You share on yourself. Can you do that, ma'am?
Yeah.
Yeah, ma'am. 1 minute. Try now, ma'am.
Okay, is my presentation visible? Is my presentation visible?
Yes, ma'am.
It is visible.
Okay, I'll start.
Yes, ma'am.
Yes, ma'am.
Good evening, respected judges, my fellow presenters, and the attendees. I'm presenting a study titled Behavior of Face Mask Usage During COVID-19 Pandemic Lockdown, a community-based cross-sectional study. As we all know, on 31st December 2019, the world awakened to a new disease, COVID-19, caused by SARS coronavirus 2, which became pandemic within a short period of time, creating a lot of havoc throughout the world. Being a respiratory disease, this can present with varied signs and symptoms. The main mode of transmission of this disease is through respiratory droplets, when an infected individual coughs or sneezes without following the cough etiquettes, and also through the contact when a susceptible individual comes in contact with the surfaces or the objects contaminated with the virus. There are many preventive strategies which is being put forward to prevent the transmission of this disease, which included following the cough etiquettes, hand hygiene, social distancing, and one of the major preventive measure which is followed is the current new norm, that is mandatory mask masking. The improper usage, the improper maintenance, and improper disposal of the face mask is both hazardous to human and also to the environment. With this regard, a community-based cross-sectional study was planned with an objective to study the behavior of face mask usage in urban and rural community. The study design is a community-based cross-sectional study carried out in the urban and rural field practice area of Ramaya Medical College during June and July 2020, and all the adults aged 18 years and above who were present at their residence during the study were included in the study. The complete enumeration of adults aged 18 years and above was done in the urban area, whereas in the rural area, from the 4 randomly selected villages, complete enumeration of adults were done. After explaining the purpose of the study, a verbal informed consent was obtained and 4,261 adults aged more than equal to 18 years were interviewed with the help of a structured questionnaire in the form of Google Forms. The data was collected regarding their demographic profile, the type of mask used, using the mask at the various settings, maintenance of the mask, and disposal of the mask, along with the comorbidities if they had any. Health education was imparted about the type of mask to be used, its safe maintenance and disposal through the pamphlets, which was designed with a lot of pictures in it for the easy understanding of the participants. Data was analyzed using MS Excel and SPSS version 18. Coming to the results, this table shows the distribution of study participants according to their age, gender, and area of residence. Here we can see that majority of the study population, that is 56%, were from the rural area, whereas 44% were from the urban area. Among the age group, people, 48.7% of the study participants were in the age group of 30 to 59 years. This figure shows the area-wise distribution of the face mask used by the study participants. 98.5% of the urban and 67% of the rural study participants were using the face mask respectively. The main reason for quoted by the study participants for using the face mask is to protect themselves, which is 68%, whereas 8.4% quoted that they use the face mask just because it is mandatory to use. Among the non-mask users, the majority of the individuals, that is 70.3% of the study participants, stated that they're not going out, that's why they're not using the mask, which was followed by 22% who stated that they go only to the nearby places, so there is no need for them to use the face mask. And 17% of the individuals stated that they do not use the face mask because they don't feel comfortable using the mask. This picture shows the distribution of study participants by the type of the mask used. Here we can see that majority of the study participants were using reusable cloth mask and also the handkerchief or dupatta, whereas 21% were using the disposable mask, which includes the surgical mask and N95 mask. This diagram shows the distribution of study participants where they use only one type of face mask. 77% of the individuals were using the reusable cloth mask, whereas 15% used the disposable surgical mask and 3% were using N95 mask. This figure shows the distribution of study participant according to the use of face mask at various settings, that is at the home front, workplace and while going out. Both in the urban and rural area, we can see that most of the individuals were using the face mask and it at all the three settings. Majority of the times, that is 75% of the times, whether at home, workplace or while going out.
Sorry, ma'am, only 1 minute left to conclude your PPT.
Okay, this figure shows that only 0.8% of the urban population and 4% of the rural population share the face mask with their family members. Out of the surgical mask, disposable mask users, 62% used to wash and reuse the face mask, and 97% of the disposable mask users were disposing it along with the household waste. Conclusion, even though 81% of the study participants were using face mask and aware of using the face mask, but they were not aware of proper maintenance disposal of the face mask, which in turn can cause various hazards to the health and also to the environment rather than saving the purpose. Hence, a community awareness regarding maintenance and safe disposal of the mask need to be emphasized to present hazardous effect to both environment and human. For the effective transmission of COVID-19, prevention of transmission of COVID-19, a comprehensive strategy using the face mask usage, social distancing, hand washing, and respiratory etiquettes must be followed. Follow-up study can be done to assess the impact of health education imparted during the study.
Sorry, ma'am, your
Some
time is
references.
it's 6 minutes over, sir. Sir, now it's time for the question and answer. You can start the question and answer.
Pavitra, did you make any specific attempt to find out where exactly and how exactly they dispose of surgical masks in rural areas?
Yes, sir. Both in the urban and rural area, the face mask must disposed along with the general household waste, sir.
No, urban area you have household waste. That's why I'm asking specifically. Rural
Okay, in
area, there is
rural area, like wherever they throw the waste, in the same place they used to dump the mask, sir.
Yeah, that is not correct. That's very important. No,
Yes, sir. So we had a pamphlet for educating these individuals where we had pictorial representation of what type of mask to be used and how to maintain the mask and also disposal of various type of mask, whether it is surgical mask, which is one-time use mask, and also N95 mask, which can be reused if
how you advise
properly
in
maintained.
the rural area to dispose of surgical masks?
Sorry, sir.
What advice you give in rural area people using surgical mask or disposal?
Yes, sir, we have told them to cut the surgical mask into half or so that it cannot be used by any other person. Then wrap it in the newspaper and dispose of separately, sir. Because in the rural area, we don't have the waste collectors for this biomedical waste. So we have told them that if it is possible, they can wrap it in the newspaper and keep it for 3 days and then dispose of with the general waste. That's all we could do, sir.
Okay, that's nice. That's nice. Nice presentation. Thank you.
Pavitra, can you hear me?
Yes, sir.
Dr. Sunil here. I
Yes,
just
sir.
want to know, whether, like you have mentioned about the usage of the mask, frequently these people were using the different types of mask related to 95 and other surgical masks. Like, major reason is like they doesn't know manner which they use it and dispose of. Any attempt was made.
Sir, you're not audible, sir. Sir, you're not audible, sir.
Sir, time up. So 2 minutes over, sir. Sir, actually, we didn't get. Sir, we didn't give the time to Dr. Vijay Lakshmi Mangasudi for question and answer. So you can start asking the questions from the ma'am, Dr. Vijay Lakshmi Mangasudi.
Thank
Can
you.
you please unmute yourself, ma'am, Dr.
Yes.
Vijay Lakshmi?
Yeah, ma'am.
Yeah, so you can ask the questions from ma'am.
Hello.
Hello, Dr. Vijayalakshmi.
Yes, sir.
Can you just tell me in one sentence what is your risk assessment of COVID-19 infection among general population? One sentence.
30% are having a moderate and high risk of getting infection if they are not preventive measures, especially if they don't use mask and if they don't wash hands frequently. So most effective measures are using the mask and washing the hands frequently. Because
What type of mask?
I have not asked the specification of the mask. I have asked whether they are using the mask regularly.
Thank you. Thank you.
Thank you, sir.
So any other question do you want to ask from ma'am?
No, not from my side. Thank you.
So thank you everyone. That was a wonderful session. Thank you to the judges for your valuable feedback and guidelines. So that's it, sir.
Thank you, participants.
Thank you, participants and judges, for your wonderful participation. Thanks, everyone.
Thank you, everybody. Thank you.
Yes, ma'am. Do you have any doubt, ma'am? I Session is over. You guys come.
Okay. Good afternoon, everyone. Welcome to the 32nd State Level Annual Conference of Karnataka Association of Community Health, hosted by Ramaya Medical College. The theme for this is the session 7. The theme for this year is redefining public health, COVID-19 and beyond. With this, we shall begin with our session, that is 7, oral presentation. PG theme is COVID. We are thankful for dedicating your precious time to judge this session. The judges for the today's session is we are handing over this to Niharika and
Chaitanya.
Chaitanya. Thank you.
Hi to sir. Oh,
on the leave. Oh, sweet. That's adorable. Oh, that's really cute. Comments. He's so sweet. Photo session ಆಯ್ತಾ?
Photo session ಆಯ್ತು ಸುಮ್ಮನೆ ಎಲ್ಲಮ್ಮ grandmother of Niharika Arora. Great to see this.
He's so God. Niharika was my most favorite shoes. Yeah, you can tell doctor.
Huh?
Doctor
After Ananthan, after one sir, it's okay, but what if one person gets up? You look young, so you calling them by not calling them.
What about the results and finger present? Yeah, they
ma'am,
are.
I think you will only get the because he only told for you like nice presentation. He didn't tell to anyone else. And we gave you one more minute, ma'am. One extra minute.
When he was asking what till end I could hear, then he asked something specific which I did not hear.
And at that time, I told time up. And then he was like,
For that, two presenters dropped out, and most of the presenters are presenting only 3.5 or 4 minutes. For judges' questions, we left the 2 minutes, 3 minutes. I am an express train, okay. Just because I had to complete 6 minutes of speaking slow, and then I hear that, okay, last 1 minute, then three figures, the last three pictures,
Yeah.
and conclusion as like rush.
Yeah. But that was good.
Last 5 minutes limit. Everyone finished in 15 minutes. Presentation means but the questions they ask are actually like the questions they ask at the department take up next question people because the time has
Ma'am, actually, this is,
access. Do we give them or you give them access?
ma'am, everyone are waiting, okay? And it's just like they are
Judges
not.
are there.
Judges is also there.
Hello.
Presenters are also. Oh, shit.
Hello, am I audible? Is there session 7 is going on or is it over? I'm Dr. Sanjeev Badigar speaking from Bangalore. Is it session 7 over or still it's not yet started?
Hello.
Huh. I'm Dr. Sanjeev Badigar from Bangalore.
Okay.
So is it session 7? I have to judge. They have
Yes,
sent a
sir.
mail regarding day 1 session 7. Is it started or is it's over?
Session 7
Time
is
given is
just about
4:30
to
to
start, sir.
5:30. Time
Hello.
given is 4:30 to 5:30.
Yes, sir. Session 7, sorry for the delay. It's about to start now.
Okay.
Was I audible, sir, or do I repeat the instructions?
No, now you are audible. Before it was
Okay.
not audible. No, it's okay.
Okay.
Yeah,
Okay. Thank you, sir.
yeah.
So, it is speaking. So, let's start the session with the first participant. Dr. Danya is, ma'am, can you hear us?
Hello.
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 Hello, ma'am. Dr. Dhanya.
Can I just presentation?
Yes, ma'am. We are passing you the presenter. You are now the presenter.
How?
Ma'am, you can present now. Yes, ma'am. I think you are starting to share content.
Start.
Yes, ma'am.
Uh, okay. Good afternoon. Today I'm next among people 7 vaccines being developed, and vaccine acceptance is crucial in controlling this pandemic. And studies to evaluate the awareness and perception about the COVID-19 vaccine will help to plan mass vaccination programs. The objective of the study was to assess the awareness about COVID-19 about COVID-19 vaccine among people. Materials and methods. It was a cross-sectional study used structured online questionnaire. The content sampling method was done among 250 residents of Mysuru district, and people who gave consent to take part in the study were included in the study, and data was entered in Microsoft Excel sheet and analyzed using SPS social results. People had excellent awareness regarding COVID vaccine. You can see that 72.55% had awareness about the vaccine producing companies, 80.39% had awareness of at least one vaccine, and 64.7% regarding the vaccine, and 8.43% knew about the complication, and only 29.41% knew about the number of doses, and 73.53% knew about COVID reinfection chances. And here you can see that majority, like fear of safety concerns regarding vaccine efficacy of the vaccine, were the factors causing vaccine hesitancy among the people. 78.43% of the people were ready to get vaccinated, and 84.31% would recommend it to their friends and family, and 60.78% would recommend vaccine to the children in their family, and 70.59% wanted government to make COVID-19 vaccination mandatory for everyone, and 90.19% wanted it free of cost. And here, when we asked whom to be vaccinated first, 38.24% wanted vaccination, and another 30.24% wanted all corona warriors to get vaccinated, while 13.73 wanted all the health workers and doctors to get vaccinated first. So conclusion, safety and efficacy concerns is the big game changer in the vaccine acceptance, and as the awareness and perception is good among good acceptance of the vaccine, and misinformation regarding the vaccine media need to be reported, action need to be taken, and also any adverse event during the vaccine trial or administering the vaccine that need to be investigated thoroughly, and also transparency need to be maintained so that rumors doesn't get spread, and
You finish now.
We finished. Now we have the question session. Now we have the question session. Ma'am, are you done?
Yes. Yes.
Yes.
Sir, it's not audible. Hello?
Sir, you can please ask questions to Dr. Dhanya.
Yes, sir. Sir, is it visible, sir? Sir, is it visible?
Sir, is the slide visible to you, the results slide?
Hello.
Yes, sir. Yes, sir, you are audible.
Okay, can I ask the question? I think sir has.
So,
Hello. Am I audible?
Okay, Dhanya. Okay.
Yes, sir.
yes, sir.
Hello?
Dr. Sanjeev.
Yeah. Am I audible?
Dr. Sudhir. Yes, sir, you are audible. Please ask questions.
Okay.
Yes, sir.
Separate set of separate slide for perception. How you captured perception?
Sir, we had made a questionnaire with awareness and perception separate, and then we had taken the opinion of the experts, and then we met the statistician, and we made a scoring system and all, and then we did a pilot study, and later we scored it. So we made a scoring system actually.
Awareness. I'm asking about where.
Perceptions, sir. Perceptions are mainly. First
Yeah,
section, we
yeah.
had asked them regarding like whether they will get
Okay, okay.
vaccinated, who they will recommend it and all. We had asked them, sir, what their perception they had asked.
Which better method to capture perception?
Yes, sir.
Am I audible?
Yes, sir. Yes, sir.
Perception. Qualitative method is the
Yes, sir.
better method.
Okay, sir. Yes, sir.
Okay, so time is up.
Okay.
Thank you, Dr. Dhanya.
Thank
Now we'll move on to the next presenter. Dr. Dhanya Joshi. Yes, ma'am, can you please share your screen?
Didn't share, it's still muted. Allow me to share my screen.
Yes, ma'am.
Share.
Ma'am, I have given the control to you. Can you share now?
Is it visible now?
Yes, ma'am, it is visible.
Okay. Shall I start?
Your time starts now.
My topic for today's presentation is comorbidity and clinical outcome in patients with COVID-19 in a tertiary care center at Goa. So coming to the back, globally in the past week, as of December 7, the cases of COVID-19 have remained at approximately 4 million new cases, and while new deaths have continued to increase to over 73,000. This brings the cumulative numbers to over 65.8 million reported cases and 1.5 million deaths globally since the start of the pandemic, as of December 7, 2020. believed that COVID-19 in those with underlying comorbidities has an increasingly rapid and severe progression, often resulting in mortality. This study aims to explore various comorbid conditions, disease severity, and clinical outcomes in patients infected with COVID-19 disease and who are admitted at Goa Medical College. So, coming to the methods, this is a prospective observational study, and clinical data of COVID-19 patients between 23rd November to 12th December were collected, and this is an ongoing study, but I took only this part. The data was using Google Sheets and R programming language. Coming to the results and discussion, according to my data, 25.8% are at age group 50 to 59, and the next coming to the age category 70 to 79, 22.6%, and next category is 60 to 69. So it is evident that above 50 years, the people are more getting not only getting affected, more the infection which leads to hospital admission is more in above 50 age category. And more males are affected, 61.3%, and 67.7% of patients don't know what is the history, but they got infection. Only 32.3% had contact with familiar or. And among my patients, nearly 80% of them had cough, dyspnea, and 35.5% of had fatigue, and all the remaining symptoms are very less. Considering the comorbidities and other conditions associated, hypertension were present in 53.29%, and diabetes 59%, and cardiovascular, coronary vascular disease 27.4%, and 11% had respiratory illness, and of persons had disorders. Among my patients, 96.2% of persons had lung infiltration, had infiltration, and others had on CT scan. And COVID-19 according to the severity, and among this, 51.6% of cases are severe, and moderate are 40.3%, and mild are 0.1%. This classification done with the respiratory rate, pneumonia, and saturation level, or other ventilation. Treatment given is like most of the patients got paracetamol, vitamin, and hydration, like oral fluids and IV fluids, and none of them got hydroxychloroquine, fluoropiravir, or oseltamivir, and 85.5% of persons got steroids, and 77% of patients got prophylactic low molecular weight heparin, 88 got antibiotics, and for 71% of persons got remdesivir therapy, and plasma therapy given for 61.3%. Supportive care at any time during the hospitalization, it's like 41.9% had ICU or high dependency unit admission needed, and 40% had high flow oxygen therapy, and 56.5% had non-invasive ventilation, and 65% patients needed invasive ventilation. Renal replacement therapy needed for 6.5%.
1 minute left, ma'am.
Clinical outcomes left is mainly pneumonia. Most of the patients, like 95.2%, had pneumonia, among which 22.6% developed ARDS, and 3.2% had death, and 33.9% are still remaining in hospital, and all others are less percentage. And among the lab values, the main one are serum procalcitonin and ferritin. And these values are increased severely, as you can see here. The normal values are like for ferritin, it is like 24.336 microgram per liter, but now it increased like 3,580 for some patients. And procalcitonin is normal, it's like 0.15 nanogram per ml, but it is increased up to 14.
Your time is up.
Okay, patient with COVID-19 had comorbidities are patients who has comorbidities has all diseases. Thank you.
Now I request the judges to ask questions to Dr. Danya.
Okay, Danya, congratulations. This is Dr. Sudhir. It's a wonderful paper, wonderful presentation. However, I have a few queries.
Okay.
Can you tell me what was your inclusion criteria? Was it patients with comorbidities or all patients of COVID-19?
All patients who admitted in our hospital in various ICU.
Okay, so the title made me think you are actually looking at comorbidities influencing clinical outcomes. So I was expecting with the title that you are mainly looking at all COVID-19 patients who had a comorbidity. Okay, so one thing what I would suggest you, if you are to improve, probably for the outcomes, you can give an adjusted odds ratio to determine which comorbidity had the highest outcomes. So for example, you said in the last slide, you had put a chi-square.
Yeah.
Okay, so probably if you can put a multivariate analysis depending on the outcome. Okay, so which particular comorbidity and the outcome was the worst. Okay, so that would be better. And also, rather than just putting chest X-ray, CT scan, if you can make it more inclusive by adding something like an CORAD score. Can you hear me? Yeah. If you can include something like a CORAD score and also changing treatment criteria. Say, for example, things like favipiravir, tocilizumab, plasma. It was not all which is coming at the same time. So probably if you had made a presentation. Yeah, I'm done.
So it is a.
Okay.
In future, I can make all this up. Thank you, sir.
Great.
Thank you, Dr. Dhanya.
Yours.
Can we request Dr. Uvia to start? Ma'am, you can share your presentation. Ma'am, you can start presenting now. Ma'am, please unmute yourself.
Sorry. Good evening, everyone. Good evening, sir. So, shall I start?
Yes, ma'am. Your time starts now.
Thank you, sir. So, my study topic is knowledge attitude practice on COVID-19 among urban and rural healthcare workers in a district in South India, a cross-sectional study. So, coming to the introduction, as we all know, coronavirus 2019, COVID 2019 is an infectious disease which is caused by SARS-CoV-2 family. And there is no specific vaccines or treatment available for this COVID-19 disease virus. And if we take all the frontline healthcare workers who encounter the patients are at increased risk of exposure to the infected cases. in my here the primary healthcare workers need to have a adequate knowledge and have good practice about the preventive measures against COVID-19 and to debunk the spread of misinformation in the community. The best way to prevent and slow down the transmission is to by well informed and educated with accurate information about the coronavirus. Here, my objective of my study is to determine the level of knowledge, perception, and practices regarding COVID-19, COVID-19 infection among the healthcare workers. So, it was a cross-sectional study done among 200 healthcare workers, healthcare workers who is working in a UHC and PHC. Here, this I have done the study in a urban and rural health center, which comes under our medical college, Jain Medical College, Belgavi. And I have done the study between May 2020 to June 2020, period of 1 month. And to collect the data, I have used a pre-test questionnaire, which consists of socio-demographic details and their questions regarding knowledge, attitude, and practices regarding COVID-19 virus. And before starting the study, I have taken written and informed consent. Later, I have applied statistical analysis. I have done by using Excel sheet by frequency, mean, standard deviation, and chi-square test. Coming to my results about socio-demographic dimension, here the mean age of the participant is 39.2 plus or minus 7.68. Here, around 42.5%, around 85 members of the healthcare workers comes between the age of 36 to 45. And most of them were females. 95.5% of the participants were female. And majority of them, 82.5% of the participants were from primary healthcare center. And 73.5% of the participants who had the education is up to PU. And here 36.5% of the participants were ASHA workers, 43% of the participants were Anganwadi workers, and 74.5% of the participants were belongs to nuclear family, and 25% of the here I have used a few questions to assess their knowledge, attitude, and practice. In knowledge, only specific questions I have mentioned. Here, around had the knowledge about COVID-19 virus, and they know the mode of transmission. Around 132 members know the mode of transmission, and few 32 members they said the COVID virus infection is 100% fatal. They have answered like this, and 179 members they know the patient can recover from the disease, and they 168 members they know the quarantine days. They answered it as 14 days, and 193 members, around 96.5% of the participants, they want to educate the public in practices. But compared to knowledge and attitude, when it comes to practice, their participation was less. So only 15. So here 31 members they said they wanted to advise. They are using mask, and 99 members they said they wanted to. They were using mask, and 15 members said they are regularly practicing hand washing and everything, and around 31 members they said they are avoiding. We should avoid overcrowding, and they are avoiding unnecessary travel. So here I have seen the association between the socio-demographic profile and and knowledge regarding COVID-19 virus. Here first I have included 11 questions. For that I have given scoring 1-1 for each questions. Out of that I have made I have divided the participant into mild, adequate, and high knowledge wise. I have divided them. Here after doing this, I have made this table. So here the field practice area and the type of housing and education were shown significance. Coming to the conclusion, here the healthcare healthcare participants were the frontline workers in the present pandemic situation. They must have the proper knowledge, attitude, and practicing skills. And here, healthcare workers in this study had adequate knowledge and positive attitudes towards the infection, but they are, when it comes to practice, they are lagging. And most of our participants were.
Thank you, ma'am. I would request the judges to please ask questions to Dr. Ubia.
Yeah, Dr. Ubia, again,
Yes, sir.
yeah, it's a nice presentation. It was a nice topic also chosen. I have two queries. First, specifically in the title, can you tell me what was the reason to mention rural and urban healthcare workers?
Sir, because sir, in
You
rural
had.
and urban, in actually what we are seeing is there are some when it comes to knowledge, they are having difference, sir.
Okay. Yeah. So I thought the same, but then what was the point in making it a descriptive study? I was expecting you to do an analytical study comparing between the urban and rural healthcare workers if you were expecting any difference. Okay, so that was my first query. So you had that in mind and you left in midway or anything?
Sir, actually, we thought of actually continuing the studies, sir, later in.
Okay. Okay. My second query, what? Okay. My second query, what do you think are the major limitations of your research?
Sir, major limitation of my study. Sir, one thing I wanted to tell is like majority of my in the study, I have taken the participants healthcare, even though they are healthcare workers, their knowledge was limited. They don't have much medical background because they are Anganwadi workers and Asha workers. By giving them training only, we will teach them because they don't have medical knowledge. I feel the knowledge, it is the limitation. And
okay. Anything about the sampling technique, the way you selected the participants?
Sampling, universal sampling, I have chosen, sir. Only two two field
No,
cut-off areas I have chosen.
no. My concern was, I think you went
Yes,
for
sir.
a convenient sampling, so the
Yes, sir.
external validity of your research will be limited. Okay, so yeah, just keep that in mind. So that were my two concerns. Yeah.
Thank you, sir.
Thank you. Yeah. All the best.
Thank you so much, sir.
Thank you, Dr. Ubia. Now I would like to go on to the fourth presenter, Dr. Sunena.
Can I share the screen? Is it seen?
Yes, no, ma'am. Can you share your screen now?
Is it seen now?
No, ma'am, not yet.
Not yet. Okay. Now?
Yes, ma'am.
Can I start?
Yes, ma'am, your time starts now.
Good evening. The topic is the prevalence of digitalized train among youth students of a medical college in Kerala during COVID-19 lockdown. Train describes a group of eye and vision-related problems that result from digital screen time. This digital eye professionals are being exposed to increased screen time. As a result, they are exposed to many complications, acute and chronic complications. Council refers this collection as digitalized syndrome. COVID-19 pandemic is a defining health crisis of our time, and as a result, students are spending more time, like UG medical students, PG, and school-going students are spending more time on digital devices like desktop, laptop, smartphones, television, and other digital gadgets. As a result, they are being exposed to many acute and chronic complications. Acute complications in the form of headache, blurring of vision, watering, redness of eyes, and chronic complications in the form of refractive errors and sleep disturbances. This study may help in recognizing the prevalence of digital eye strain among the medical students and the factors affecting digital eye syndrome. Coming to my objectives of my study, to study about the prevalence of digital eye strain among the UG medical students of MES Medical College and to identify the factors causing digital eye strain. Coming to methodology, a cross-section study was conducted among UG medical students of MES Medical College in Kerala during August 8, 2020 to September 5th, 2020. A pre-structured validated questionnaire was used along with socio-demographic details. This HAZE questionnaire I have validated. That questionnaire has got a Cronbach's alpha of 0.8. I have calculated the Cronbach's alpha as 0.8, and I have also used the details on digital screen usage. The questionnaire was sent through Google Forms using social media. Working definition which I was used is, if any one of the symptoms, that's the 10 symptoms in HAZE questionnaire, is present after prolonged digital screen time, the person is said to have digital eye strain. Medical students of MES Medical College, Malappuram, from first year to internship are included in the study. Those who are having known eye diseases, excluding the refractive errors, eye infections, migraine, and those who are not willing to give consent are excluded from the study. Sample size was calculated as 150 by using the formula 4PQ by D squared. Is 30.8% from a similar study done in Dehradun. Convenient sampling was done. Data is entered in Microsoft Excel and analyzed using XPSS version 25. Coming to the results, most of my study participants are 24%. Most of my study participants used smartphone as their digital, and most of 57% of the study participants used 5 to 10 hours on their digital screen, followed by 18.1% which used more than 23.3 for 3 to 5 hours, and 18.1% using more than 10 hours. And on this digital screen use, 83.9% used digital screen in dark room. And average distance of digital screen from eyes to the screen was about 2 palm distance for 62.2% of the study participants. 77.7% used digital device before going to sleep regularly. In my, I found 91% of the study participants having digital eye syndrome as prevalence. I've used KACHCON test for finding association between the variables and this digital eye syndrome. I found significant association for gender and for hours spent on screen in dark room, and taking frequent breaks while using digital screen, and usage of digital screen before going to sleep, details of objects seen after prolonged hours on digital screen, and these are the ones which was having significant association. To conclude, we found the presence of one or more DES-associated symptoms in 91% of the population. We found there is statistical significance between the digital eye strain and gender, hours spent on screen in dark room, frequent breaks while using digital screen, usage of digital screen before sleep, and details of objects seen after prolonged hours on screen. Hello?
Yeah, 1 minute left.
Okay. So that's showing importance of reducing the exposure to digital screen, especially in dark room before going to sleep, and increasing frequent breaks while using the digital screen. These are my preferences. Thank you.
Thank you, ma'am. Now I would request the judges to please ask questions to you.
Yeah, Sanjeev sir has left the meeting. Okay. Anyways.
No, I'm very much here.
Oh, sir. So please, after you.
Okay. Sorry, it was because letters were very small. Have you asked about equipment used for attending all this this thing? What are equipments they have? Screen length, because sometimes
Most
screen
of
is
them
more.
were using.
Hello.
Most of them were using smartphones as they. Hello, am I audible?
Okay. Yeah. Okay.
Most were using smartphones as their digital.
Because why I am asking is smaller the screen, more the eye strain. And,
85%.
hello, there is a lot of disturbance. Hello.
Hello.
Yeah. I think rest of the people can
Yes,
unmute.
in my
Otherwise,
study
there is a lot of disturbance. Okay. Go ahead.
In my study itself, this 95% had used the digital screen as microphone. I mean phone.
Okay. So few might have, because these students are medical students. Okay, they may use laptop also. You could have asked how many of them are using laptops.
Only 5% were using laptops.
Okay.
193 study participants, 5% were using
Okay. Because
laptops.
you were screen. Okay.
Yeah. Dr. Sunaina, again, a very apt topic. Congratulations, a good presentation. My concern was, you specifically mentioned you wanted to capture during COVID-19 lockdown. So how did you address this in your study tool? How did you address the information bias?
Sir, I didn't get you.
No, this can be medical students' screen time. What you mentioned can be even before COVID-19 lockdown, right? They might have used this even. Yeah. So how did you capture this? Yeah. Okay. Yeah. Please tell me.
Actually, this COVID-19, as a result of this COVID-19 pandemic, we had a nationwide lockdown. As a result,
No, that's fine. No, I think no. I'm asking you, how did you capture it in your study tool? How was your study tool designed to capture this? That this question is specifically to COVID-19 lockdown. How did you capture this?
Sir, I have done this study lockdown period. I have done in August 8th, 2020. And we are being online classes now.
No, exactly. That's my concern, because you said smartphone usage was the highest usage. 95% was smartphone use. Okay.
Because most students are using smartphones for their online classes. I have asked the question.
No, that screen time can be also for browsing other things during pre-COVID also, the pre-COVID times. So did you ask specifically to ensure COVID-19 lockdown, was it increased? Was the questionnaire designed to capture the COVID-19 lockdown?
Yes, sir.
Okay, can you tell me what were those? Because I'm thinking about the information bias which can be there in the questionnaire. That's all.
No, after this lockdown, your screen time, whether it is increased or decreased. Asked a question like that in that questionnaire.
Okay, have you presented it here? No. Okay.
You want to see the question?
No, it's okay. Okay, thank you. All the best. Yeah.
Now I would request the first presenter of the day, Dr. Divya. Dr. Divya, ma'am, you can share your screen.
Yeah, I'm sharing.
Yes, ma'am. You can start.
Can you start?
Yes, ma'am, your time starts.
So, the title of my study is Factors Affecting Attitude and Practice Towards Novel Coronavirus Disease Among Adults of Mandya City. To introduction, so it's almost 1 year since the first case of COVID-19 was recorded, and if we see now globally, there are about 76 million cases with 21 million of active cases and 1.69 million deaths. So government is also taking remarkable measures at both state and central level. So the point is that how much the people adherence it's towards such measures, so that it can be assessed with the help of their behavior and practices towards the COVID-19 measures, so that the outbreak containment can be successful. So the main objectives of our study is to assess the attitude towards various aspects of COVID-19, to assess the practices towards the prevention of COVID-19, and to assess the factors affecting attitude and practice towards COVID-19. So we conducted a cross-sectional study in the, from July 2020 to September 2020 among the adults of Mandya city. So by taking the proportion of positive attitude in the previous study, that is 33.4% with relative precision of 10%, we got a sample size of around 800. We did a multi-stage sampling method. So if we see in our Mandya city, there are about 8 divisions. So under that 8 divisions, one PHC is randomly selected, and under each PHC, one subcenter is randomly selected, and then all villages were covered under that subcenter with the help of probability proportional to size sampling method, and then the number of households are selected by systematic random sampling after calculating the sampling interval. So one adult from each household, those who are aged above 18 years of age who gave informed consent were included in our study. And we interviewed them using a pre-tested semi-structured questionnaire, and the attitude and practice was assessed with the help of scoring system. So we did both the questions, attitude and practice questions. It is based on Likert scales. So for attitude questions, the total marks was about 40 marks. So those who scored more than 80% were considered to have a positive attitude, and less than 80% negative attitude. And coming to practice, the total score was around 24. So those who scored more than 80% was considered to have good practice, and those who scored less than 80% was considered to have poor practice. So we did descriptive and inferential statistics like chi-square test. So here the table 1, it shows towards COVID-19 among our study subjects. So if we this is measured on a Likert scale, that is very afraid, slightly afraid, and not afraid, and 3-point Likert scale, very important, and not important. So if we see to questions like whether how much they were feared about COVID-19 pandemic, or themselves acquiring the COVID infection, or quarantine or isolation for about 14 days, or mortality, that is COVID death. So majority of the participants said that they were afraid. And if we consider the questions like how much they were afraid about traveling to other places, or visiting neighbors, or visiting crowded places, so majority of them reported like they are slightly afraid. Then with respect to preventive practices like wearing mask, hand washing, social distancing, and cough etiquette, so more than 80% of our subjects considered it as very important. Table 2, it shows practices towards COVID-19 among our study subjects. So this practice questions, it is also assessed in Likert scale, that is always, most of the time, occasionally, and rare. So when we among our study subjects, nearly 3/4 of our subjects were wearing masks for most of the time, And more than half of our subjects were practicing social distancing occasionally. And with respect to hand hygiene, maintaining adequate cough etiquette, and visiting neighbors and washing vegetables after purchasing. So majority of our study subjects were practicing it for most of the time. So table 3, it shows factors affecting attitude towards COVID-19. We considered factors like age, sex, religion, educational status, socioeconomic status, and residential status. So attitude differed with respect to sex and socio-economic status. So where majority of them had positive attitude among males, and majority of positive attitude was found among upper socio-economic status. And it is also found to be statistically significant. And coming to table 4, it shows factors affecting practice towards COVID-19 transmission. So here also we considered factors like age, sex, religion, educational status, socioeconomic status, and residential status. So practice differs with respect to educational status, socioeconomic status, and residential status, where majority of them had good practices who were educated up to college, and majority of those who belonged to upper socioeconomic status had followed good practices, and majority of those who belonged to urban population had good practices comparatively, and these differences are also found to be statistically significant. So conclusion, factors like sex and socio-economic status differ with respect to attitude, and in our study subjects, factors like educational status, socio-economic status, and residential status differ with respect to their preventive practices towards COVID-19 transmission. Thank you.
Thank you, ma'am. Now I would request the judges to please put their questions across Divya, ma'am.
Sanjeev sir.
Hello.
Sudhir sir, Dr. Sudhir sir.
Yeah,
hello.
yes, sir. Okay, sir.
Hello,
yeah.
am I audible?
Dr. Divya,
hello.
Good presentation. Good presentation.
Yes, sir, you're audible. Yes, sir.
Okay, doctor. I think he asked me to ask the questions. I think he'll ask later. Dr.
Yes.
Divya, it was a good presentation. Again, an important topic. However, I have two queries. Can you tell me why did you choose probability proportional to sample size sampling technique?
Hello.
Dr. Divya, can you hear me?
Hello. Yes. Am I audible?
Yeah. You're audible. Can you just tell me why? I was just curious enough to know why did you choose probability proportional to sample size?
Sir.
Did you know the population of each of these villages beforehand? You said probability proportional to population.
Yes, sir. We have. Yes, sir. We have the list.
Okay. What was the
list
reason for choosing this?
Sir. How many under villages? How many households are there under each village? List is available, sir.
Yeah. Can you tell me why PPPS instead of a simple multi-stage cluster? I am just curious.
Sir, it's not clear.
No.
Sir.
Why did you choose PPPS over a multi-stage cluster? Can you hear me? Hello? Am I audible?
Hello, sir. It's not. Yes, sir. Now it's audible.
Yeah. Why did you choose PPPS?
Sir, because I need 100 households from each of the villages. We covered under each sub-center. So I chose since there are different different number of households in each villages. I selected that PPS method.
I think, Dr. Divya, there will be a selection bias issues here, because if the number of, it's not based on the households actually, it's based on the number of people who are there in the village. And if there is no gross differences, like a village has only 1,000 people and another village has, let's say, 5,000 people, and you want to capture that number, then PPPS would have been helpful. Okay, and mainly for behavioral studies. And my second question is, when you said inferential, I was looking at multivariate analysis. I could find only chi-square. Did you try to calculate an adjusted odds? Hello? Hello, am I audible?
Yes, sir, you are audible.
Yeah, Dr. Divya, have you tried to calculate an adjusted odds for the factors for your third objective?
Adjusted odds, I didn't calculate.
Okay, okay. Yeah.
I'll proceed with that, sir.
Okay, all the best.
I'll proceed.
All the best.
Okay, sir.
Okay, Dr.
Yes, sir.
Yeah. You conducted survey among households, isn't it? How whether you have included, sir, you have selected one per person from each house. How many households you have surveyed, included in your study? All the households you have included? Okay. No, I am asking, during household survey, how many households from each house you have included? All the households present in the house you have included? Hello.
Hello.
Am I audible?
Yes, sir. Sir, yes, sir. The question is how? Can you repeat me the question, sir?
During household survey, how many people from each house you have included in your survey? From each house?
One, sir. One adult. One adult only, sir. One adult aged more than 18 years.
Okay, yes, okay. Done. My part is done. Okay.
Thank you, ma'am. Thank you, sir. So with this, we conclude.
Thank you.
I would like to thank all the presenters for their amazing PPTs and presentation. Also, we would like to thank the judges for their questions and their valuable contribution towards this. Thank you so much for joining.
Thank you, organizers, and thank you.
Thank you, sir. Thank you, ma'am.
All the best to all the presenters.
Thank you.
Thank you, sir.
We would like to end the session now.
Sure.